right. Hello, everybody. And I'm Erin, and welcome to the Trial Site News Podcast for Farrago. And today we are going to be talking about long COVID and a potential treatment that is in the works. My guest today is Dr. Randall Urban. Thank you so much for joining us, Dr. Urban.
Sure, happy to be here.
And before we dive into the interesting work you're doing on long COVID, do you mind just introducing yourself to our viewers and telling them a little bit about the work you do?
Sure. My name is Randy Urban. I'm a professor and an endocrinologist at the University of Texas Medical Branch in Galveston, Texas. I've been a clinical researcher, being someone who does research primarily in patients for the majority of my career. And over the last, it's hard to believe, but over the last 20 years, we've been doing research around traumatic brain injury. And we've been interested in changes that happen to the endocrine system, those are the hormone system in the body, when a traumatic brain injury occurs. And in the course of doing those studies, we've come up with some very interesting findings, and we've come up with an interesting syndrome. And when the COVID infection hit and we began to hear reports about long COVID and the symptoms related or caused in the long COVID syndrome, we found that a lot of those symptoms that our patients complained about who had traumatic brain injury were very similar to some of the patients with long COVID. We understand that there's a whole spectrum of symptoms associated with long COVID, but we looked specifically at those symptoms that related to our syndrome that we were studying in the traumatic brain injury patients, which we call brain injury associated fatigue and altered cognition, or BIAFAC. And we found out that many of those symptoms were similar, and which led to the studies and what we're going to talk about today.
All right. Well, you already answered my first question, which was how you got interested in long COVID and started to do research in that area. And we're going to focus on your latest study published in Clinical and Translational Science in June of 2024, titled Growth Hormone Treatment for Neurologic Symptoms of Post-Acute Sequela or Lasting Effects of COVID-19. But first, can you take us back a little bit when you did that case control study, which I believe you published in January of 2024, to tell our listeners about how you identified that, yes, there is low growth hormone in this segment of the population that has long COVID?
Sure. Well, going back again to the patients that we were studying with traumatic brain injury, when we looked at the function of, there's a gland that sits right behind your eyes. It's called the pituitary gland. And it sort of dangles on a stalk at the base of your brain. So it is connected to the brain. You know, the blood flow and all this is in a connection to the brain. But we were very interested in whether damage to the pituitary might affect those hormones that the pituitary makes, and that damage might end up affecting your health. And so when we had studied our TBI patients, our traumatic brain injury patients, we found that a number of these hormones that are made by the pituitary could actually be malfunctioning or not be being secreted properly. And one of the major ones was growth hormone. So growth hormone is, of course, what we all need in order to grow, but we think it also has important properties later in life as well. So we were studying that growth hormone levels and found that they were abnormal in our traumatic brain injury patients. And so when we saw that the symptoms from our traumatic brain injury patients that had this BIAFAC syndrome were very similar, we said, let's start first by seeing if the patients with long COVID also may have abnormalities in growth hormone secretion. So that's what we did. We did a relatively small study where we took patients who had a history of having, the SARS-CoV-2 infection, and then had afterwards developed the long hauler syndrome. and were severe enough that they went to a clinic that we'd opened at our university, University of Texas Medical Branch. And when we studied those patients, we found that they too had abnormalities in growth hormone secretion in response to the COVID infection. So that's what led us to the next step, was to say, wow, if the growth hormone is abnormal in these patients, just like it is in our traumatic brain injury patients, maybe they'll respond in a positive fashion like our traumatic brain injury patients do to growth hormone.
And I wanted to ask you, you talked a little bit about the function of growth hormone. When we had a previous conversation, you talked a little bit about the microbiome, or the bacteria in our gut, which, everyone's talking about the microbiome today. It's sort of fascinating, all the research that's ongoing in that area. But can you tell our listeners what potentially is the link between low growth hormone, the microbiome, and long COVID?
Yes, we currently are working on in science, you do a hypothesis, right? So you sort of say, well, what is going on? What all this started from is in our traumatic brain injury patients, we found that they did not absorb essential amino acids like folks who hadn't had traumatic brain injury. So what are essential amino acids? Well, amino acids are the building blocks of muscle. So amino acids are put together, they form proteins, and these proteins serve many functions in the body, but also they are important for us developing our muscles. But these essential amino acids are also used in our brain as neurotransmitters. So they are absorbed, pass through the blood-brain barrier, and are converted in the brain to signaling molecules between our neurons. So we were wondering whether perhaps this inability to absorb the essential amino acids normally could be clinically relevant in why our patients with traumatic brain injury had these symptoms. So we really started looking at the gut microbiome in our traumatic brain injury patients. And we found that it was very different in terms of the gut compared to controls. Now, what are controls? Well, your gut microbiome is very much influenced by what you eat. So we wanted to, as controls, we used the staff who worked at the facilities where these TBI patients were staying long-term to see if there was a difference. And lo and behold, there was a very significant difference in identifying the bacteria between the two. So that really made us start raising the question, could there be something going on in the microbiome of the gut that were leading to the symptoms that these patients were presenting after these severe traumatic brain injuries? So it led to a long series of studies where we really looked at this, and we identified this brain injury associated fatigue and altered cognition syndrome. We actually took the bacteria from those patients who had this syndrome, and we put them in mice. These were germ-free mice, so they're mice that are specially bred that have no bacteria in their gut. So we gave them the gut microbiome of our patients with the Bifax syndrome. We put it in these mice, and lo and behold, the mice developed the same symptoms as our patients. Now, the fatigue and the foggy brain, I mean, how do you assess that in a mouse, right? It's kind of hard to, do that, but we have things where we put these mice on a rotorod, which is a turning rod, and the mice that got the gut microbiome from our patients with the syndrome couldn't stay on that rod as long as mice who we gave them the gut microbiome from normal people. So this has really indicated to us that these mice with these bacteria in their gut were developing the very same symptoms as our patients. So that really has led us to a much broader hypothesis of what's going on. What we think happens is that whenever there is a trauma or maybe a severe infection, like a SARS-CoV-2 infection, that something happens to the bacteria in our gut. And we hypothesize that these bacteria have a change in their energy metabolism. So they're normally living with us, they're in the symbiotic relationship. We're eating all this great nutritious food. they're able to generate all the energy that they need to live. And so we're all sitting there singing Kumbaya and everything's great. Well, all of a sudden, this event happens in the human. And when that event happens in the human, something happens to that whole community, that whole realm where these bacteria are living in our gut. And the bacteria begin to change their metabolism. They go into a state of sort of an energy deficient state, or an abnormal energy state, where they begin to say, use different nutrients in order to continue to live. And we think that what may happen is one of the nutrients that they may start doing is they may start beginning to take these amino acids that we are normally absorbing and going to our brain as neurotransmitters and begin to metabolize them for their own energy. So we think that's what ultimately leads to not only the traumatic brain injury, the biofact syndrome, but also this long haulers or long COVID syndrome that occurs. Now, it doesn't occur in everybody, so we still have to understand why it happens in some and it doesn't happen in others. We don't know the answer to that. And we also don't know why growth hormone solves the issue. So what we found in our traumatic brain injury patients is when you give them growth hormone and they have these biofact symptoms, these symptoms get better very significantly. We like to do a scale of 1 to 10, where 10 is when you're at your peak and 1 is when you're not functioning. And most of the patients that come to see us with the biofact syndrome are functioning at a 3 to 4 level. When we give them growth hormone, they go to like a 7 or an 8. They don't go back to a perfect 10, but they get so much better that they're functioning with it. And so these long COVID patients who develop these symptoms, they're very similar to our traumatic brain injury symptoms. So that was our question. If we treat them with growth hormone, if they come in with a 3 or a 4, and we treat them with growth hormone, are they going to go to a 7 or 8? And the answer, well, I may be taking your next question, but the answer is, yeah, they improve just like our biofact patients. So we were very excited about that response. And we feel that it's all the same mechanism. And some of these chronic fatigue syndromes that are out there for which people have no treatment for, Lyme disease, where people, get these same sort of symptoms, people with bad rheumatologic diseases like rheumatoid arthritis, any kind of connective tissue disease, they may have these same feelings because this whole syndrome may get set up and may be what's leading to everyone having these feelings. Or cancer patients who undergo chemo and go through the trauma of the chemo may change the bacteria and lead to that foggy brain, which a lot of women talk about, like after breast cancer treatment.
So the microbiome, full of mysteries, potentially connected to all these different types of illnesses, where folks kind of bounce around, right, to find answers,
right.
Which is it's a super frustrating process for a lot of people.
Yeah, one of the things that I've started doing is I will have, when the patients come to see me, they've usually been to at least 15 other doctors, and they've all been told by their physicians that they're depressed. They have they're getting older and not adapting. I mean, they have all sorts of reasons. And I walk in the office and I say, so you have fatigue. Your fatigue is profound. You never have a good day. You have to take naps at lunch. If you try to do a task, you can't finish it. You have trouble concentrating for long periods of time. You have short-term memory loss. You can't remember things. You have slow processing speed in that you can't handle information like you used to. You don't want to go out to dinner with friends because you can't really quit back and forth with them. And then when you do think of the word to say, your spouse or friend fills that word in for you, which gets you upset. And you lose your executive function. You can't make it through the day without making a list, whether you make that list on your phone or you make that list on a piece of paper. And that's how you function. And usually when I give them those symptoms, which are the core symptoms, for both this long that we pick in the long hauler patients and are the number one symptoms in our biofact patients. They usually become emotional because now instead of a physician telling them they're crazy, I'm actually telling them their symptoms. And it's sort of like just a big relief to them to hear that.
Sure. It's reassurance.
I'm not crazy.
Right. It's validating, like, hey, yeah, what you're feeling is real.
And a lot of these folks are real go-doers. And so they say, I know that I'm not a crazy person, right? I know I'm not crazy. This is real and no one will listen to me. So it becomes very frustrating.
All right. So let's jump into the most recent study that you published, in which patients with long COVID received daily growth hormone injections for a period of 9 months, I believe.
Right.
Okay. It was 13 adults. So it's a small study that you're doing here. And could you talk a little bit about what you were looking for, what you measured, and some of the results?
Sure. I mean, the primary thing that we're looking for is, do we get an improvement in their fatigue? And do we get an improvement in the surveys that we use to assess for memory, that sort of executive function, those key elements. And what we found is that these patients responded just exactly like our traumatic brain injury patients, our biofact patients. They got better on the same time course. So in our biofact patients, it takes about 3 months for the fatigue to go away, and it takes about 4 to 5 months for the foggy brain to clear. And we saw this happen in these patients almost exactly like we do in our biofact patients. And we actually have we didn't put this in the paper, but I actually have a slide which shows the response of the different surveys for our biofact patients on the top, and the bottom are for the long COVID. And the scales move exactly the same between the two patients. So we were very encouraged by that. Now, one of the reasons that we only did this for 9 months and we had this 3-month on the end is because what I've found in my patients is that treating with growth hormone is not a cure. It relieves the symptoms, but it doesn't cure these bacteria from what they're doing. In that when you stop growth hormone, in about 3 months, the fatigue comes back. In about 4 to 5 months, the brain starts getting foggy. So we built this into the study to say, well, if once we stop the growth hormone, are their symptoms going to come back like our biofact patients? Maybe if we treat with growth hormone, the bacteria will change, and maybe we won't need to continue to treat. Maybe in our long COVID patients, we can just treat them for a year and stop, and they'll be back to their old selves. So that was our thought process, is maybe they won't react exactly like our traumatic brain injury patients. But unfortunately, they did. They did, except for one person. So, a case of one means absolutely nothing, but I think in some ways it does mean something. It's not in the paper at all. You won't see us mention that. But we had one very young woman. She was in her 20s, who was actually living in Sweden at the time, who flew over to the United States and stayed in the United States so she could do the study. But once we stopped the study, her symptoms have never come back. So for whatever reason in her, that growth hormone treatment solved all of her symptoms. And when we stopped, she continued to functioning at a high level. And so it's making us raise the question as to whether, we're studying folks longer since the brain injury or longer since the COVID infection, right? So we're usually 9 months to a year after that happens. And maybe she responded so well because she was young. It was fairly recently after the COVID infection. And maybe we intervened early enough where her system could reset. And we're starting to look and think about ways that maybe we can intervene sooner after an infection or sooner after a brain injury. And that if we do something to improve the energy milieu of that gut microbiome, where those bacteria maybe don't switch into this different metabolism. Maybe that would prevent this from ever happening. We're designing a study right now to try and test it, but we haven't even started doing any testing yet on it. Again, with our goal being, maybe we can even prevent this whole syndrome from setting up if we intervene early. We don't know the answer yet or not.
So just to emphasize, you're talking about basically treating the microbiome first versus giving someone the growth hormone.
Right.
Okay.
What we're thinking about is there's a fermentable fiber that you can buy over the counter called inulin, inulin. And because it's fermentable, the bacteria love it. So we're thinking what the studies that we're designing is maybe we can use inulin early on in folks and then follow them and see whether they end up developing the biofact, which happens, or the long COVID, which occurs later on. And if maybe intervening early on, we might be able, by just giving them this simple fiber, it is fermented, so it can cause bloating and cause gas. So I wouldn't advise everyone in the world to run out and start, taking a bunch of inulin, but until we can show that it works. But it's just an example of how we think that this may improve the energy state of that community of gut microbes so that maybe they don't flip over to this different metabolism, which begins using these amino acids. That's our working hypothesis and what we're thinking about.
Now, you mentioned you designed the study. I know your studies, and you could talk a little bit about this since it's trial site news about, the funding for your studies, which I think is an interesting backstory. But at what stage do you think you'll be ready to recruit for this type of study? Because I think a lot of people would be interested in it for sure.
Oh, well, the thing that limits us, and thank you for that, is money, right? Getting dollars to do these studies. So this type of work is, it's first of all, it's clinical research, and we do things with this type of research that are they're a little risky, not risky to the patient, but risky in terms of the science, right? It's an innovative thing, and the way that NIH is designed is very rigid, and you almost have to have proven what you're doing before you can get a group of scientists to agree to give you the funds. That's not a criticism. That's how NIH works, and it's done miracles. But this work that we've been able to do, because we originally started looking at this after a philanthropist in Galveston Island, his name was Robert Moody Jr. He had a son who'd had traumatic brain injury. And he came to me way back in 1990 and said, I think there's pituitary dysfunction after brain injury. And I looked in the literature, there was nothing about this. And so I went back to Mr. Moody and I said, I don't see any evidence of that. And he said, well, if I give you the money, we could do the study. And we did. And that's when we found this 30% incidence of pituitary dysfunction. And that's really led to all of this work. And the ability to help so many people, to have people come to you who are pretty destitute and return them back to being functioning it's just quite a privilege. It's something that to be able to do that and to have been given the resources and the possibilities to doing that. So these studies that we want to do are pretty broad reaching, and really I don't know if NIH is geared to be able to fund these type of studies. So someone who, is part of a foundation or knows of a foundation or a group that is interested in funding something like this, certainly contact me. We'd love that. I don't want you to think that we don't do good science. That's the other question. We have grants funded through NIH, which are more specific and more following along the lines. And the super innovative stuff that we're doing now, though, really benefits from philanthropic support.
And part of this podcast is to demystify some of these things with scientific research and clinical research. So just to get folks thinking about, what is funded, what gets studied, gets published, and can dictate a lot of things such as standards of care and that kind of thing. So,
But if Mr. Moody had not come to me and done this, we would have never known that there was pituitary dysfunction after brain injury. We would have never focused on growth hormone. We would have never come up with this BIFAC syndrome. We would have never been able to help so many people with this and return them back to essentially normal function. And now we may, when we published some of our work on the brain injury people, we felt that those papers that were published in 2020, we felt that they didn't get the play that they should have, because that was right in the middle of the pandemic, of the SARS-CoV-2 pandemic. But the reality is that pandemic and COVID now, and this long haulers COVID, has just broadened our view of everything and opened up us thinking in much broader terms and thinking of something that affects many, many more people. And it's those really broad, innovative things that are difficult for organizations like NIH to pull together to fund, because they have to stay in their particular programs and their particular function. And again, NIH is wonderful. I'm not knocking them. It's just a little bit different thing that we're doing and been able to help people.
So going back to your latest study, can you get into specifically, you saw significant improvements in fatigue, mood, but sleep and cognition,
So this study was a little bit shorter in how we did it.
Okay.
And we've developed a new survey for people specifically with brain injury associated fatigue and altered cognition. It's called the FACS survey. And so that FACS survey is, we've just published that in PLOS ONE. And so that's really more geared towards this. The cognition piece that we studied in that particular study, where we didn't see a difference, is a less sensitive study. So a lot of these cognitive studies are designed for people who have fairly severe dysfunction, right? So they're people who that it's not sensitive for someone. If you're who is a highly functioning individual and then loses that ability and can't do their job anymore, that person on the cognition test usually won't show any difference, because they're going to score well, even though they're tired and fatigued and their brain's foggy. They're still going to score well on that cognition test. And even after their brain clears and they have energy, they've already pegged that test. So that's the reason, like, for example, that particular cognition test didn't show an improvement. This FACS survey, which we hadn't yet developed to the point where we could utilize it in this study, is much more sensitive. And we've been using that, and it's been showing much better this improvement that people have. Now, the sleep is an interesting one, because
I thought so too, because of the fatigue.
Yeah. Now, very clearly in our brain injury associated fatigue patients, sleep does improve. That's a clear. Now, it may be that we didn't study quite enough people. We had a small number. The patients who came to see me, and who I saw who took it, and some others who've come to see me, have talked about their sleep improving, but not as much as our TBI patients. So, maybe there is some difference there. I'm tending to think that it has to do with the time or the length, right, of this process, because most of our long haulers patients were within, since 2020, so within the last 4 years. Most of our TBI patients are usually longer. Some of their brain injuries occurred 10 years ago. And so I think we may be starting to see some differences between that acute state, or as this thing develops, and where in the process you intervene and what difference it could make along that pathway. Don't know that for sure, but we didn't see an improvement in sleep. So that is something that if it's really dramatic, we probably should have seen it. So that seems to be a difference that we'll have to study as we go forward a bit more.
In the study, you talked about how when you stopped the growth hormone treatment, the symptoms came back by and large for the long COVID patients. Is that also what you see for the traumatic brain injury patients?
Yes. Yes.
Oh, okay.
Yeah. No, that's why we did that. That's why we repeated those studies 3 months after, because we were really curious if the COVID patients were going to respond the same way. And it's, one of the problems we have is getting growth hormone. Insurance companies will only pay for growth hormone if you have true growth hormone deficiency. And it's very difficult to make the diagnosis of growth hormone deficiency. It's not like you can just check a blood level and see what your growth hormone level is. You have to stimulate its release. There's a lot of variability in that. People have developed these very rigid numbers that we give a stimulant to make the pituitary release growth hormone, it's actually glucagon, and then you measure over time to see how high the growth hormone goes in response to the glucagon. And if it goes over 10, has a big peak of growth hormone, then that's perfectly normal. There's nothing wrong with it. But then they have all these other. Well, if it goes below 3, then you're deficient. But if you're heavy and it goes below 3, you could still be okay. Every value has to be less than 1. And so it's very arbitrary. So if your assay growth hormone measurement turns out 3.5, they say, you're not growth hormone deficient and we're not going to give you growth hormone. So getting the patient's growth hormone is very difficult. And a lot of times insurance companies will just cancel their growth hormone. They'll be on it for 10 years. They'll be doing great. And they'll just say, no, we're not giving it to you. So we have to go back in and appeal again. And it's in those times when our patients are off growth hormone that those symptoms come back just every time perfectly like they did when they went away. In other words, in the first 3 months, the fatigue comes back. In the next 4 to 5 months, the foggy brain comes back. Once they're able to get their growth hormone again, takes another 3 months for the fatigue to go away, another 4 to 5 months for the foggy brain to get better. So patients are very aware of this, and so they're very worried because they know that if they can't get their growth hormone in about 3 months, they're going to be back to where they were before all of this started. So we were really wondering whether the long COVID patients would respond the same, and they did. Except for our one exception. Those symptoms started coming back again in them, just like in our BIFAC patients.
So you're an endocrinologist and hormones are your specialty. And I think when folks hear growth hormone, especially this idea of perhaps being on growth hormone for many years, people might be scared about the side effects. Some folks are worried about the risk of cancer. Can you speak a little bit on that?
Yes. I've been treating patients with growth hormone now for over 20 years. Now, that's not me collective. That's me treating an individual patient who I saw back in 1992 or 3, something like that, and have been treating them with growth hormone for all these years because I can't stop it. Once I stop it, their symptoms come back. And I've got a cohort of about 150 people that I've been treating this way for that period of time. Now, in that cohort, over that period of time, which is about 20 years, a few of them have developed breast cancer. One of them has developed prostate cancer. But I see that as just the normal aging process. For me to be really alarmed that I might be doing harm, I would have expected, 50 of the 150 to develop a cancer if there was something really there that I was concerned about clinically. Now, statistically, just by me treating such a small cohort, that's not enough statistics to say that there isn't an increased risk, right? You would have to study many times over with growth hormone over that period of time to be able to positively say that it's not an increased risk. So I can say that in my clinical experience, I haven't seen an increased incidence of cancer with growth hormone treatment. But I can't tell you that going on the growth hormone may not increase your risk down the road because we just don't have enough numbers to make that statement. But the patients feel so much better and their quality of life is so much better that I think even if I told them there was a 10% greater risk of cancer and we're going to monitor closely, they'd still go for the growth hormone because of the difference that it makes in their lives.
Yeah, and I think it's just important for folks to have all the information and they can decide for themselves what route they want to take. But perhaps this whole microbiome study that you're working on might be the real gold, so to speak.
All right. We're looking for better ways. You know, I mean, the first thing that comes to most people's minds is, well, how about a fecal transplant? You know, let's just grab the stool from a normal person and put it in these people and see if they're good forever. I don't feel really comfortable with that because of all the things. I mean, you can sterilize it as much as you like, but it's still, I think, not something that I would recommend. We are trying to identify, we've got a cohort of approximately 20 bacteria that seem to be the troublemakers, that seem to be the ones who switch over to this altered energy metabolism. So we're getting to the point where we're thinking about maybe if we can really confirm this and get it nailed down better, we can create sort of a cocktail of these bacteria that we could try to put into these folks who have the syndrome to see if introducing these new, well, we wouldn't introduce these bacteria. We would know the bad guys, and we'd introduce in a cohort of good bacteria to kind of push out these guys. But we really need to identify these bacteria so we know, how we're going to push them out if we try and do that. But it's not a simple thing because, bacteria, you have to get the bacteria across the stomach, right? And the gastric area, and that it has a pH of 2. And a pH of 2 is usually lethal for most bacteria. So, there's ways to get it past there. There's also going in from the other, direction, suppositories and things like that. So we really haven't started tackling that problem. We want to get more to what are really the bacteria who we think are the problem, and how can we maybe use other bacteria to kind of push those guys out. So it's really a question of how do we change the bacterial milieu, or how do we do something like prebiotics, probiotics or bacteria that you're trying to get there, prebiotics or, different amino acids. Do we increase amino acids? Do we use inulin? Is it a cocktail that has inulin and amino acids and maybe some bacteria that are going to, what are we going to come up with that might be able to change this? Or could we develop a small molecule that would target those bacteria and be able to switch their metabolism back to a good metabolism? Then, so there are all of these possibilities that we might come up with. Or maybe that still doesn't help. Or maybe we have to do growth hormone and these other treatments to get person back to a perfect 10. We don't know any of those answers. We got to figure them out because I'm no spring chicken and I've got to get to the answer to this before I retire, right? So we got to get this.
So you need the funding, right? That's what funding.
Oh, yeah, that would be great. Thank you again.
Well, if anyone is interested, anyone tuning in, who may want to fund the studies or know an organization who might be interested, they could contact you, Dr. Urban, perhaps?
Sure.
Okay.
Perfect.
All right.
And rurban@utmb.edu. That's my email.
And I will include that in the podcast description, as well as some of the links to your recently published studies. And thank you so much, Dr. Urban, for joining us. I find this topic fascinating, and I think the microbiome is fascinating, particularly, in what the areas you're working on and how broad it might go. So I hope you get some of this stuff funded and studied for sure.
I'm an endocrinologist, I'm a hormone guy. So when we first started talking about the gut microbiome, I'm going, what? No, that's not it. That's not it. And it wasn't until we did the studies with the mice, when we
Yeah.
actually take the bacteria from the patient, put them in the mice, and they get the same symptoms.
Hmm.
That was our answer. That's when we knew that
Right.
that the gut microbiome is the cause. And I really think that some of the greatest advances in medicine in the next 50 years are going to come from this very complex interaction between
Mm.
these colonies of microbiome, of microbes in our gut and our
Hmm.
health. I think we're just at the tip of the iceberg. We have no idea, no clue about all the complexities that are happening in these communities in our gut.
Right.
And we have really smart people that'll figure it out in the future. And these studies that we're doing now, I can see in 50 years, they'll laugh at them and say, what were these people were so, uneducated and didn't know what they were doing. But
Well, you have to start somewhere.
you got to
Um,
start somewhere. So I feel
yeah.
like we're those dumb guys that are starting at the beginning.
Yeah, but we could all look back in history and be like, man, we were idiots, but
Yeah,
they actually
I know
weren't during.
they're gonna look back on our studies and go,
Well, it brings new meaning to follow your gut
oh,
anyhow.
sure. I love that.
All right. And thank you to all our viewers for joining into the podcast. Be sure to subscribe and also check out Trial Site News for articles on the latest scientific research breakthroughs and some opinion articles as well.